Psychoanalysis, mixed personality disorders, calls for revision of DSM-5. Namaste. Personality disorders are among the most pervasive of disorders therapists and psychiatrists encounter. Ironically, contrary to what DSM would have liked it to be, we see most personality disorders cases as those of the mixed type. Conversation today is on this difficult and complicated subject with psychoanalysis consultant Dr. Himanshu Vaidya. Namaste, sir.
Namaste.
So why enter this phrase of mixed personality disorders?
One, because it's very common. In most chronic pathology, in most pathology where we see a relapse, in most pathology where we see resistance to cure by regular medication or regular therapy, we see there is an underlying personality disorder. Not always, but most of the times. So there is an episodic problem on the surface which comes to us as a presenting complaint. But below that presenting complaint is a personality disorder at the foundation. So this is a very normal picture of pathology that we see, especially in India, where if we look at mild, moderate, and severe, mild hardly comes for therapy or counseling or even medication. We are dealing by and large with moderate and severe, and in most of the cases we find underlying personality disorder. So that's one reason why it is necessary, because it is one of the most underdiagnosed categories.
Right.
For most chronic pathology, relapsing pathology, resisting pathology, often there is an underlying personality disorder which is never diagnosed. And because it is never diagnosed, there is no question of curing it, because you don't do anything to what you don't diagnose. And when that happens, the efforts either don't give result or they give short-term results. So the healing process faces severe impairment because of our lack of being able to diagnose and recognize a personality disorder where it is there, but it is hidden. So it's very necessary to have a good grasp of personality disorders for most of the difficult pathology that we look at. So this is one part. The second part is, this is an area where medication cannot do much except for a very few of the pathologies. And even in those cases, the symptoms produced are tackled with, the real pathology can't be touched. So for example, if you have bipolar, one of the most medication open personality disorders, what you can do is you can treat the mania, you can treat the depression. You can't treat the underlying disorder which produces those cycles. So the personality disorder area is where, in a deeper sense, in a long-term sense, only therapy works. It's only in emergency situations that medication helps. And of course, that help is very useful, but it can be life and death issue. But if you look at long-term healing, this is a chapter in DSM where only psychotherapy or counseling would work, and mostly psychotherapy would work. So this is very important for therapists as much as for psychiatrists, because often, because it is not diagnosed, nobody is referred for therapy. And the relapse keeps happening, resistance keeps happening, not responding to medication keeps happening. Chronic nature of the sickness keeps remaining chronic. So this is one part of it, why we have to go into it. And the second part of it is this concept of mixed personality disorders is one of the areas where DSM needs a revision. DSM-5 definitely needs a revision. And this revision is in many areas. We'll touch upon it later. But to start the discussion, there is a severe limitation in DSM, where we see somebody diagnosed with either A or B, but rarely A and B. And we see most cases, and we encounter this more in therapy than in psychiatry, that when we are with a patient for a reasonably long period of time, we see that below the presenting personality disorder, there is another personality disorder, either partial or traces of it. But there is actually a constellation of a mixed personality disorder. It's rare to find only one personality disorder. You always see traces of something else, some other PD, or a partial other personality disorder hidden below the one. And therefore, more in therapy, even in psychiatry, but more so in therapy, it becomes very clear to us that most personality disorders are actually mixed personality disorders. And it is not an exception, rather a rule, that most personality disorders are mixed type. What happens if DSM is revised and takes care of these things? What do we need? We need that first, it should be recognized that there is something called a mixed personality disorder. Two, once we say it is possible, many combinations and permutations can happen. So there are 10 personality disorders. You can have somebody with 2, somebody with 3, somebody with 4, somebody combination 1 and 4, somebody 2 and 5, and you can have many combinations. Some of the common combinations have to be given a nomenclature. So the identification, communication, research, healing, all of that becomes easy and develops faster. So first is to give name to those combinations, because classification gives us clarity. Classification also helps us to focus our efforts, and it helps to develop healing knowledge and techniques faster. So classification is very important. When we get into the classification of mixed personality disorders, conceptually, when we look into it, psychiatry finds itself in trouble. Because this idea that there is a mixed personality disorder, this is a difficult idea, because once you accept coexistence, it automatically opens up the prospect of cogenesis. That if two personality disorders coexist, or in most cases mixed personality disorders coexist, then the idea that each personality disorder develops from a separate line of development, that comes into question. And what becomes more feasible is that maybe they are all emerging from one common phenomenon. Coexistence leads to the idea of cogenesis. And this is a terrifying idea both to psychiatry and also to CBT, REBT. It's only psychoanalysis which has the conceptual framework where a common genesis of so many different personality disorders can be explained in something. So in a hidden way, in ways which they don't understand, they don't realize the unconscious anxiety that is there with accepting coexistence, because it leads to cogenesis, possibility of cogenesis, that is terrifying. So this is one of the very important ideas, which I think the idea has been erased unconsciously, willfully. It's a paradoxical thing to say, but it's an unconsciously, willfully kind of situation, that the idea has been erased. And unless we expand the DSM chapter of personality disorders and accept the common existence of mixed, and we label the most common ones, psychiatrists, therapists, counselors, they will all fall short of the empowerment of knowledge for correct diagnosis and correct cure, or correct healing like this. So this is why it is so important to first revisit the chapter of personality disorders, to accept the existence of mixed personality disorders as most common, the rule rather than the exception. And 3, from there, start the journey towards developing concept and techniques for healing them.
So very rightly explained, sir, that in the therapeutic setup, we come across with our clients who have cluster of different symptoms which have overlapping different personality disorders. At the same time, working on the pathogenesis and the story of the pathogenesis itself can give us a deeper understanding of what all coexisting PDs can be there.
Right.
So coming to these combinations and permutations, can we have some examples of mixed personality disorders as seen frequently in practice?
There can be many examples of it. Let me just give a few that I have come across in my practice, because I think if any questions come on those, I can answer them better.
Right.
The first common is narcissism on the surface and dependence below it.
Okay.
It's a very important combination, because normally, by normal understanding, we believe that they are opposites. How can a narcissistic person have dependence? And how can a dependent person have narcissism? They are opposites. Like, you cannot feel hot and cold at the same time. But we see that paradoxically, these opposites coexist. That often I see that we have narcissism on the surface, and deep below, there is a severe dependence, a desire to find some parent figure or some person on whom to depend completely and let go of everything and be taken care of.
I usually called it the child narc.
Right.
There are some adult narcs and there's some child narcs. So I call them child narcs.
So there is a dependence below narcissism, and the two paradoxically coexist, which by the spirit of DSM should not happen. By the spirit of CBT also should not happen.
Exactly.
Then we have the second combination, which I have encountered quite common: histrionic on the surface and narcissism below the histrionicity. So on the surface, there is histrionicity and almost a submissive nature, which looks like dependence. But below it is narcissism. So you have histrionicity on the surface, below it narcissism. Second combination, histrionicity on the surface, dependence below it, and narcissism below it.
Okay.
And one by one, these things open up in therapy as you do long-term therapy. They won't come up in short-term therapy. You really have to do a long-term therapy to really see it all unfolding naturally.
Layer by layer.
Layer by layer. And very naturally, very organically. You don't need a technique for that to happen. Just have a safe therapy and it will unfold by itself. The secret will manifest. Then the third is bipolar on the surface and OC below it. Very common combination. Fourth is combination of three. Bipolar on the surface, dependent below it, and OC below it.
OCPD.
OCPD. And the moment there is stress on the top two, the third one becomes active and becomes florid. The fourth is combination of narcissistic personality disorder and sadistic personality disorder. Very common. Narcissism on the top and sadism below it.
What usually ideally people in general public identify narcissist with sadism. It is easy for them to identify one.
Similarly, you can have the other part, narcissistic and masochistic, where masochism is on the top and narcissism is
right underneath.
Yeah. Then we have bipolar and masochistic, another common combination. And these are the strong bipolars with heavy earth element, as we discussed before in some other discussion.
Right.
Very well-built women, very well-built men physically, with very heavy earth element.
Mm.
And usually they would be bipolar 1 rather than bipolar.
Actually. True.
But they can be bipolar 2 also. And in bipolar, the masochistic personality disorder is below the bipolarity.
Mm.
And analytically speaking, the masochism can be because of high preponderance of the death instinct, of the twisted pleasure intensity, and also to escape the inertia and deadness inside by some pain. So the pain also provides a sort of excitation to escape from the stillness of inertia, that horrifying absolute cosmic stillness of inertia. Mother who used to work with Sri Aurobindo, she used to say that when you go into the center of inertia and you actually experience the full power, you will feel that a stone is vibrant with activity compared to it. Pure inertia is so difficult. It's absolute. It's almost like absolute cessation of all movement. A stone, by comparison, seems to be very active.
Mm.
Because the entire atomic activity is still on inside the stone. The electrons, the protons, the entire activity is on. But in pure inertia, there is no activity. So anyway, to escape that inertia, often masochism is used. It can be used other ways also. It can be inverted sadism also, as we have discussed before. Another combination is of schizoid on the top and narcissism below it. And one of the most common also is antisocial personality disorder and narcissism. So we can see that these are very common things that we encounter. And if we treat any personality disorder long enough, we definitely find some other personality disorder coming. May not be as strong, but definitely worth diagnosing and worth treating. I mean, it requires treatment. All the components, all the personality disorders we see, they need treatment. And in therapy, they have to be healed one by one. So the question naturally is, if you don't recognize, if you don't identify, how are you going to treat? That's the first condition for treating it. So these are some of the common combinations.
Somehow, practically, many of the beginners therapists would be confused or afraid to be over-diagnosing their clients, because whenever they're coming in touch with these cluster of symptoms which come to or fall under one specific category, they tend to pick up those which are actually creating dysfunctionality in life in certain ways and let going the other aspects. And very correctly, as you were sharing the permutation combinations, I was getting in touch with those aspects that many of the times there is no pathology, but you can still identify the traits which when succumb to difficult situations, person would get activated into. So it comes in the stages and phases of life where certain criteria would be activated. So when these different set of life situations and in the coping, the psyche is operating to pick up certain cluster of traits, where does co-occurrence lead us in terms of causality to have a better understanding of that they can coexist all the PDs?
Before I answer, just a comment to what you said about young therapists. When you miss the hidden personality disorder, often the patient tells you. We don't understand it, we don't take it that way, but often the patient tells you. Say for example, somebody has come to you for bipolarity and OCPD. Bipolarity is why the person was brought to you in the first place. So if the person would say, I have come for depression, and then over a period of time, or with case history, good case history, if the person is honest, or over a period of time, you conclude it's not just depression, it's bipolarity. So then one personality disorder is diagnosed. And then you come to realize there is also OCPD. But you don't realize there can be dependence. But the patient tells you, you don't understand what I'm trying to say. So when you tell the patient that this person is troubling you, why don't you be away from that person? I mean, it's an obvious solution. And after having suffered so much, you should not even need anybody to tell you. You should be doing it on your own. Why is it that you suffer so much and I have to tell you to separate? This is something a person should be naturally doing. And now, even with my telling you, you can't do it. What you should be doing, even without my saying it, even without my knowing it. So that is where the dependence comes, and the person says that you don't understand how I cannot live without this tribe, without this group of people, without a person A or a person B. So that is where we start knowing the dependence. And often we realize, and I have realized it, that at times that is the most critical thing, that the thing to come up last actually was the most important of all personality disorders which are presented.
True.
And unless that...
The rest have followed.
Yeah, because unless that is healed, no other personality disorder is going to be healed, to whatever extent we are attempting healing.
True.
So often the hidden personality disorder may be the point from where the deepest of healing can start. That may also be the point where all the healing efforts at the top are being resisted and they are not taking effect.
They are a disguise to protect that core PD.
So the most repressed is the most important. So coming back to what the question you asked, this was just to add to what you said. Coming to the causality of it. Now there are two ideas. The idea of DSM and CBT and REBT and everyone else is, apart from psychoanalysis, is that each personality disorder has its own path of causality. That the narcissist may be very pampered, the dependent may have been trained that way, OCD have been attacked many times for not being clean or orderly, and therefore there's nothing common between them. They all are coming independently with independent causal pathways. True. That is one way. The moment we talk about mixed personality disorder and coexistence, then it leads to a second idea that maybe there is one common trauma and all these are emerging from one single event. And that's a very different idea of causality.
Yeah, and channelizing further.
Yeah. And in psychoanalysis, we understand that early life object loss can be that event from which all the personality disorders emerge. So the different personality disorders are actually multiple ways of coping with the same event. It's like you are hungry and you take a sandwich, you also take a cup of tea, you also take a chocolate and so on. There are multiple ways simultaneously you do to cope up with one event, the hunger inside. And
in fact, sometimes that's which confuses the therapist when there is presentation of certain symptoms, but DSM-5 would prefer at least 5 or 6 of them. But while you see just 2, 3 of them playing out, because further the psyche has managed to push across somewhere else, and there it is emerging as some other 2 3 more symptoms, and then the therapist can be confused.
Correct. So this is where the difference is between the DSM and psychotherapy, at least psychoanalytic psychotherapy. For us, it does not matter as therapists whether the DSM criteria are met or not. Even if they are not met, but if the difficulty is present, we have to address it. We may not be able to write a diagnosis, that's a law point. But in healing, there is no way you can ignore a difficulty, regardless of that being labeled or not labeled. If the patient says this is a difficulty, if the family says this is a difficulty, everyone around says it's a difficulty, the therapist feels it's a difficulty, a problem to be solved, even if it's not diagnostic, under DSM, you still have to address it in therapy. The psychiatrist may not be able to give medication because that is law. You can't treat somebody who has not been diagnosed. But in therapy, that is not the law. So it's a different context of healing, where we are more liberal in accepting pathology and dealing with pathology. And therefore, psychoanalysis tells us that loss may be early life object loss, may be that event to cope with which multiple personality disorders are developed as dysfunctional solutions. And they are simultaneously developed and they coexist. And on basis of it, I have developed a Valley Junction model, which is the model for causality ascertainment of personality disorders. How the psyche undergoes a series of feelings and thoughts and events after the event of object loss, and how in that journey, based upon other constitutional factors and based upon pre-event and pre-event experiences and the constitution of the person, different disorders are developed. Now, one important point here is when does this critical traumatic event happen? So in causality, the important point is that there are two ways of looking at causality. One is different ways of each personality disorder developing. Second, all of them actually develop from one event. And what is important in that model is, when did that event happen? The earlier, the worse. And second, what were the experiences of the child before the event happened and after the event happened? Let us say object loss happens at 6 months of age or 3 months of age. Let us say 3 months of age, the object loss happens. And the constitution of the person is reasonably okay. But in the first 3 months before the loss, he had very good experiences with the good breast. Now that is very critical. That is what will lead to a personality disorder and not a psychosis.
True.
If the earlier 3 months also were traumatic and the constitution was not very fragile, the same loss would have led to psychosis. So what is very important, number one, when does the loss happen? Number two, before the loss, what was the experience? And number three, after the loss, what is the experience? Over a long period of time, do the parents fortify further the pathology or do they help in healing the pathology? So over the time, training also is important. And in most cases, unfortunately, parents end up fortifying the tragedy. And that is where the difficulty comes, that the personality disorder is actually strengthened by inexperience of engaging with the parents. Socioeconomic conditions, of course, can add to it. One movie I'm going to analyze next Sunday is about Skyfall, a James Bond movie, where James Bond loses both his parents when he is a child. And you can see the manifestation of it. The child has no option but to develop narcissistic defenses. The helplessness and the anxiety is so high and so unbearable that he has no choice but to develop narcissistic defenses. And he has no choice but to develop the violent streak in him. Because now he is living in a world where, as he sees the world, it is the world of either you hunt or be hunted, kill or be killed. But the important point is, when the object loss happened, before that, the child was able to absorb a good superego. And therefore, he becomes a patriotic James Bond and not a mafia person. The same person, if he had not internalized a good superego, the same person would have been a combination of narcissism and antisocial. But now we have a combination of only narcissism. But the scar that it leaves is, apart from narcissism, he also has a permanent problem with emotional closeness. And therefore, the James Bond always lives alone. Having lost a family, he dare not create a family because there's too much fear of losing and the subsequent pain. So the fear of loss and the fear of pain of loss won't allow him lifelong to get close to somebody enough or to have a family. And he uses sex as a defense against emotional closeness. So we see how the early life traumatic event becomes a cause of a personality disorder. And as I said, experiences prior and later to that event are equally important. So this is how we can look at the causality of personality disorders. Very different from the current idea of each personality disorder having an independent causal path.
This Khalil Gibran talks about the big T and the small t. So here we take the earliest T as the big T, and then subsequent life choices and experiences at small t, which add on to the disguise of underlying personality disorders, having functional personality. Somewhere I'm getting into, there's certain personality disorders in people which are very in action, which is very functional, you can see. And as you say, these inert underlying the ones which are actually getting fed by the surface personality disorders are those underlying personality disorders.
Correct.
So when we see all this in a big framework of healing, how do we go about it?
We have only 2 minutes to go for this session. Should we take up in the second part this question?
We continue in the part 2 of the same. Thank you.